the last session. Thank you all for being here. Individualized therapy. You know, every article used to end with a paragraph, we need to do more research, and now every article ends with a paragraph, we will need to do personalized medicine. And for some, that's an excuse to ignore the evidence. For some, it's a way to say that we still need money to do research in the upcoming years. Maybe a way of admitting that we actually have no clue what we should do, or maybe to acclaim ourselves experts and to say, well, you need an expert, so you all need to ask us what you should do. Or maybe it's something we all can do with the limited evidence we have, and I will have to explain you that with the limited time I have in 15 minutes. And so I'm going to try to make 4 points. First of all, that the physiology of ICP is not so difficult, that there's been good epidemiological work, but that doesn't justify the binary threshold we've seen, that there's no such thing as a negative clinical trial, and maybe, well, finally, when I want to tell you how to do it, that there's a toolbox of things with which we can work. So why do we measure ICP? We measure ICP, and we've measured it since the 70s, as a warning signal of deranged perfusion. That's why we calculate the CPP, and as an indicator of mass effect. That's the 2 reasons why we monitor this. No more and nothing less. Now, where does this, like, you know, that the previous guidelines had a threshold of 20 millimeters of mercury, where does this come from? Epidemiological work. There's a couple of other studies as preceding this, but mainly the study by Tony Marmaru, who showed that the proportion of measurements of ICP above 20 millimeters of mercury was associated, it was most indicative of outcome. Now, from that epidemiological association, which I'm sure you all think is very logical, if your ICP is higher, you have a higher probability of not doing so well, they had a recommendation that has stood for more than a decade. That means that you should initiate therapy at 20 millimeters of mercury. Does this mean that at 19 millimeters of mercury you shouldn't initiate therapy, and then at 21 millimeters of mercury you should do a decompression? I mean, what is treatment? What is initiation? It all didn't make sense. Now, luckily, we have new recommendations now, and look at the new recommendations. What do they say? Aha! We have to treat at 22 millimeters of mercury. Now, that's going to solve the problem of all of us, I suppose, because now we have a new threshold above which we should worry and below which we should not worry. Of course, that is not true. And let me tell you what this guideline is based upon, and you will see immediately why this is not true. So the group of Cambridge, they did a study where they retrospectively looked at data of TBI patients, and they did sequential chi-squares of ICP and outcome. And they found out that an average ICP over your whole stay of 22 in the whole group, was associated with outcome. Now, based on that one study, of course, you can't make a real recommendation. And Giuseppe Citerio and I, we wrote actually a letter to the journal complaining about the simplicity with which they found this guideline. And an additional argument was given to me by Nino that indeed an average ICP over a stay is not really something you can use as a treatment threshold. But on top of that, and the group of Nino has studied this, we know that there's small measurement errors in our ICP tracing, and clinically that's not relevant, that's not that bad, 2 millimeters of mercury. But if you think about thresholds above which you're going to do dramatic things and below which you're going to be conservative, of course that is not good. In addition, we must never forget that all epidemiological work is being done in patients in whom ICP is being treated. So you might just see it as a reflection of not being able to control ICP. The concept of dose of ICP I will come to. We will talk about the studies that have done early aggressive management, and also in this study, different subgroups like women, like geriatric patients, even had other thresholds. So I think the mistake was in the paper that they talked about threshold, which weren't really threshold, and in the guidelines that they actually interpreted it as threshold. Now let's look at the clinical trials. And people are always unhappy when a clinical trial doesn't give the result they expected, and then they call that a negative clinical trial. Now, any good clinical trial is never negative. So the DECRA trial was negative in a sense that they weren't happy that an early decompression didn't improve outcome, but it gave us an answer. It gave us an answer that a practice that most of us would not do, I suppose, but still do a very early decompression even after a brief episode of an ICP above 20, that dramatically increases your likelihood of doing worse. So that's an answer. We know now that we don't have to do a decompression so early. Another trial that is often quoted as a negative trial is the BEST TRIP trial. And I don't have time to talk about the BEST TRIP trial, but the BEST TRIP trial was not a trial of intracranial pressure monitoring. It was a trial comparing two strategies to aggressively treat the ICP. Only in one arm they measured the ICP at the same time, and they treated at 20 millimeters of mercury. In the other arm, they also treated ICP aggressively. And what did they find? The same outcome. So it appears that if you treat ICP, or if you treat ICP, the outcome is the same. You can be more efficient with an ICP catheter, with an ICP measurement in place, which obviously to most of us will make sense. Third trial that is perceived to be negative, the hypothermia trial. What did they do? Very early, so ICP above 20, in the first 10 days, for more than 5 minutes, you would be randomized on top of tier 1, would be randomized to hypothermia or not. And what did they see? If you apply this also very extreme and aggressive measure that early, that the patients do worse. So this is a negative trial if you like hypothermia, but this is a good trial that gives us an answer that we don't have to do hypothermia that early. Now, not a negative trial, so this sort of doesn't fall in this series, is the recently, or the most recent of the 4 trials, the Rescue ICP trial. And so they did a decompression at a later stage, ICP above 25 millimeters of mercury for a prolonged time, something we would all not be happy about. And they found that indeed they were able to decrease mortality by being so aggressive. But there was a price. And the price was that more people ended up in the severe disability range, but also there was a benefit because after 12 months, they found that there were actually some people who benefited from this intervention. There were more people with with a good recovery in this group. So it's a double answer, and this is a difficult trial to interpret. I think we can talk about this for years or months even, because this will also involve taking into account the wishes of the relatives, the wishes of the patients. But this gave us a clear answer. So we had thresholds, which I think is rubbish. We had interventions, and then we have treatments. Once again, think about thresholds. So we have all these treatments. So we have, and we can step them up, and we can discuss on where we put them. I think we would all agree that decompression and hypothermia are very risky, so should be reserved for a limited group of patients. So where are you going to put your threshold of 20 here? Is this the threshold to increase sedation? Is this the threshold to drain CSF? Is this the threshold to hyperventilate? Is it the threshold to do hypothermia? The threshold to do a decompression? So a threshold doesn't give us a real answer there. What does give us the answer then? That's what I will try to answer in the next 5 minutes. We have a whole lot of monitoring tools, and the thing is that we need to interpret them. First of all, not all TBIs are equal. So some TBIs have a high risk of an increased ICP, some types have a low risk of increased ICP. Some causes of ICP, such as a subdural, which has a high risk of increasing the ICP, but is something we can solve relatively easily by calling our good friends the neurosurgeon, and they can drain it. That's not the same as somebody who has an ICP because of severe edema surrounding a contusion, for example. I don't have time to go into all these monitoring tools in detail, and I'm sure you know them, and I'm sure you can read about them. But what we should think about when we treat our patient, or when we want to individualize treatment, we want to think about which part of his physiology is deranged. What is my problem here? Is the problem a problem of intracranial compliance? Do I have a problem with perfusion? Do I have a problem with substrate delivery? Do I have pathological brain activity? And in function of the suspected problem, as you would do with any other condition, you suspect a problem, you do a test, and you see whether your hypothesis is right. So that's what you do. And based on that test, you select an appropriate treatment. So will I have to do one of these? Will I have to do a decompression? Sorry, I put that up twice. Will I have to increase CPP? Maybe I have to transfuse the patient. Maybe I have to sedate them. Maybe I have to give barbiturates. And then we have to evaluate, and that's the advantage of being able to monitor. Then we have to evaluate, is there an effect? Is there a lack of effect? Maybe our hypothesis was wrong. Or is there harm because of the treatment? Maybe we just missed the point. We increased CPP and we caused edema, for instance. And this table doesn't have the ambition of being complete. Okay, so it's something I made up, so don't take picture of it and say that it's the new gospel, but it's just a way of thinking. We have certain treatments we give for a certain type of deranged physiology with certain dangers and with certain things we can monitor in addition to the clinical exam and to the ICP. Suppose we monitor ICP. So if we augment CPP, we know there might be cardiopulmonary complications. We know we might worsen brain edema. So we might want to look at these things and evaluate whether our therapy did something. If we want to sedate, we know we will fail to detect neuro changes, so we might need more monitoring to see what's going on. We might prolong mechanical ventilation. We might cause a propofol infusion syndrome, something I talked about a couple of days ago, and so on. So all these therapies have drawbacks, all these therapies have dangers, all these therapies have their places. Do we have trials to tell you where to put them? No. But we have ways of looking what we should do and evaluating that. And also, a danger of monitoring is that you start treating based on that monitoring. And you know the old joke of the guy, the drunk guy at night who was looking for his keys at the lamppost on the street, and a cop would stop and he would ask, hey, have you lost your keys? Yeah, I've lost my keys. So he helps searching. They can't find the keys. And then he asks, yeah, but where did you lose them? Well, I lost them over there, but there was no light, so I came looking here. And that's what often happens with monitoring. You have a signal that is not a problem, and you start treating that signal at the same time ignoring where the problem should be. And so the future of individualized management might look like this. This is the cockpit of the newest Boeing Dreamliner, where we have a visualization of the problems, where we no longer look at numbers separately, but where attempts have been made to integrate that, and apparently for pilots it's a lot easier to fly and interpret. And there's several of these cockpits in a number of fields. We don't have a neuro cockpit for the moment, but that's something we might want to work to. A way of integrating all the information, because it's sometimes too much for a human being to interpret. Do we have additional tools that we can look at? Maybe things that are under development or that are being developed? Well, we can look at the dosage of these ICP. So it's not only crossing a certain threshold, like here, but it's also the time that you're below the threshold that is important for outcome. So in this study, we didn't look at patients, we looked at different types of ICP insults, and we looked at their association on average. How many of these insults does a patient do, and how does this explain his outcome? And we find this association, which is intuitive for all of us. I mean, if you're above 20 millimeters of mercury for 5 minutes, well, okay, we're not happy, but we know that this won't kill the patient. If we're above 20 millimeters of mercury for a couple of hours, then we are worried. And so maybe there is a way in the future to display the dose of ICP to people. And the dose of ICP is important, the dose of ICP, but depends on other factors as well. For instance, if your autoregulation is active or passive. This is a PRX, an index designed by the people in Cambridge. So if you increase blood pressure and the ICP goes up at the same time, this means you're not autoregulating because you're just swelling. You're increasing cerebral blood volume and you're increasing the ICP. Whereas if you autoregulate, you would expect the vasoconstriction and you would expect the ICP not to change or maybe even to decrease. And the dose of the ICP is different depending on autoregulation, and it's more predictive than a fixed ICP threshold. So there is something in there. This is actually another way of telling the same story. So if you autoregulate, you're a bit safer than if you don't autoregulate on the left. And let me finalize with this slide. And maybe in the future we can find ways to predict future problems, like the MoCAIP algorithm, where they look at the morphology of the ICP signal. You can look at the amplitude of the ICP signal, or you can maybe use machine learning to predict future ICP rises. So to conclude, people think about neuromonitoring as seeing below the surface and seeing below the top of the iceberg. But actually, we don't see below the top of the iceberg. We're sitting in Plato's cave. This is what's happening. And we see reflections of what's happening in the brain reflected on the wall of the cave. And we have to try to make the best out of this. Thank you.
Thank you, Geert, for very nice talk.
Thank you.
Any questions from the audience? Hans?
Hans Friberg, Lund, Sweden. I have a question with regards to individualized medicine. Do you see any dangers with this approach?
Yeah, I think the danger was in my first slide. I think the danger is if you start ignoring evidence. I think the danger is if you take your field of hypothermia, there's studies that were negative, there's clearly practices that we don't do anymore, and then still finding an excuse of doing them in your patients while ignoring all the evidence, while you know that these patients have been studied and we've shown that it's bad in those patients, and then under the umbrella of individualized therapy, ignoring this and still doing it. Yeah.
Okay. No more questions from the floor?